So this is our flow chart for patients in active labor. And the chart starts here with this key question: is birth imminent? And so we need to talk about specifically what that involves. How do we determine if that birth is imminent? And of course, there's things like, has her water broken? Are the contractions close? Is this her first baby, or she's had several babies before? Does she feel a need to push? Can she feel that a part is presenting? But really, it kind of starts with introducing yourself, getting a hand on radial pulse, and asking a couple of questions pretty quick while you're headed for the need to take a look and see if there are presenting parts, and that's best done during a contraction. So you approach your patient. Hi, my name's Brian. I'm a paramedic with the fire department, or whatever the appropriate introduction is for you. Get a hand on that radial pulse and then say, so it looks like you're in active labor. How far apart are your contractions? And unless she gives you a number of 5, 6, 7 minutes or longer, you're pretty much going to need to take a look right away. And you can say, ask, has your water broken? Of course, she can deliver and have not had her water break yet, so that doesn't always help. Is this your first baby? And of course, first babies take a lot longer to deliver, but you have no idea of knowing where you are in the time frame here. And certainly if she says, this is my third baby, then she probably has a lot more experience with this than you do. And she knows you're going to need to take a look. So as you look, you would like to look while she's having a contraction. And look, and you're trying to see, is there a cord presenting? Is there a head presenting? Is there a foot? A butt? Is there a leg? What do you see that's presenting, or is nothing presenting? And so as we kind of move along to the right here, if you look and you see a cord presenting, you're going to need to say, okay, well, I see the cord, which means that we need to position you in a certain way, and we're going to want to try to delay your delivery until we get to the hospital. If you see a limb or butt presentation, you can say, well, this is a limb, I see a hand presenting, or I have a breech presentation, and we're going to need to position you in a certain way and try to have this baby in the hospital. Now, this positioning for any of these that is not a head. So if you see head presenting, then we'll move on to that here in a minute. But if it's anything else that's a presenting part, we need to position her to use gravity to our advantage to keep the baby from delivering, which means her rear end is going to need to be up in the air 4, 5, 6 inches, whatever you can work out with pillows, blankets, and towels and such. And we're going to need to urgently transport. We're going to need to take some help with us, and we're going to do vitals and get some more of her OB history as well as the rest of her history on the way. Paramedics are going to consider tocolytics. That's usually going to be in consultation with the hospital, and the plan's going to be to get moving and then deal with that consideration of tocolytics while you're on the way. If you see nothing presenting, and that's not all that uncommon, a lot of times EMS is requested for transportation, for a ride to the hospital where the patient is not imminently ready to birth. And in that case, you can go ahead and move toward the ambulance. Let's do some things, vitals and history and that sort of stuff while we're on the way. And we would like to position that patient on her left side if possible, if not on her right side, but not supine. And it wouldn't be a bad idea to have some blankets and pillows in place to raise her rear end a little bit. We probably don't want her head down. That's going to promote nausea during the transport. So the head of the bed is up a notch or so, maybe 30 degrees if you're able to estimate that. And then we're going to move on toward the hospital. So it really, the key question, as we said at the outset, the key question is this birth imminent? And that's going to involve you needing to take a look during a contraction and then report back very professionally, as calmly as you can. I see this, and therefore we're going to do this. Now, if you do see head presentation, the patient is crowning. Now we move down into this sort of area down here on the chart. And if the head is delivering, excuse me, if the head is delivering, then we're in this game right now, right where we are. We need the OB kit opened as quickly as possible. We need to prepare to deal with a very sick newborn if that happens, and a very sick mom if that happens. Fortunately, most of the time neither of those happen, but we need to be prepared for both of those. As the head delivers, you'd like to have a little bit of back pressure on the bony area of the infant's skull, and not on the fontanelle. Just a little bit of back pressure, not much at all. You're just trying to keep that head from delivering explosively and causing mom to have a perineal tear. As the head comes out, you want to look around the neck for a nuchal cord. Nuchal cords can almost always be simply slipped around the infant's head, so you insert a couple of fingers under the cord on each side of the head and just kind of work it back and forth, get some slack, and that cord will usually pop up over the infant's head. If it's double wrapped or triple wrapped, it's probably not going to come off. That's very rare, but in that case you would need to clamp and cut. Anywhere you can get two clamps near each other, side by side, cut between the cord, or cut between the clamps, cut that cord between the clamps, and then the infant goes, it needs to deliver right now if at all possible. But again, that nuchal cord thing is usually not very, it's not very common. When it does happen, you can usually manage it pretty easily by just getting some slack in that cord gently and slipping it over the infant's head. Once the infant's head emerges, you want to suction mouth and then nose with the bulb syringe. Mouth, then nose. The mouth has a larger space, has more fluid in it. Plus, once you tickle that nose at all with that suction, they're going to start breathing. So we want to clear the mouth and then clear their nose and expect that they may start attempting to breathe. As the infant progresses and moves on out and his chest delivers, chest can expand some, and that's going to trigger all those events in the first breath and the change in being an air-breathing mammal. And so we want to keep that nose clear as best we can. That would be great if she could not push during that time. Maybe she could pant and avoid pushing, but you need to be quick and get in there and get that suctioning done. Then the next thing up is delivering the baby's shoulders. Sometimes the shoulders will become stuck a little bit. You can usually manage that by reaching in with your hands, one on top and one on the bottom of the baby, kind of guide the baby down to get that shoulder to clear mom's pubic bone. Excuse me. That's what's hanging up. The shoulder's hanging up on mom's pubic bone usually, and you can usually guide that down gently, and you'll be all right. Once the shoulder's clear, baby's coming out. And once he's out, the very most important thing for you to do is dry him off and keep him warm. Dry him off with a towel, and then get a dry towel as warm as you can find, and we need to keep that baby warm. And so what happens then is that we end up heading off into a different algorithm, which then is a different video screencast about that. Let's go ahead and take care of mom now at this point. So you've handed the newborn off to your partner, and now we're going to work on mom. We need to know, is there more than one baby in there? If there is, if we're dealing with multiples, then you're back to the start with the whole crowning situation and what kind of presentation do we have, prep for delivery of that second infant. Those multiples, the second and successive ones, tend to be abnormally presenting breech. They tend to be smaller. They tend to be more likely to be in trouble. And so it may be that first birth was relatively simple, but hang on, the game's not over. The second birth in these multiples is more likely to have issues than the first. If we don't have multiples, which is usually the case, and you haven't gotten an IV yet, and you're a paramedic, now's an okay time to get one, because there's kind of a break in the action until the placenta decides to deliver. Placentas come out whenever placentas want to come out. Sometimes it's a few seconds, sometimes it's up to half an hour. When the placenta detaches from the uterine wall, there's going to be a gush of blood, which may be surprising and intimidating. And it's one thing for there to be a release and a kind of a gush of blood. It's a different thing and a bad thing when that is a continuing heavy bleeding. If you have that excessive bleeding and you have not clamped and cut the cord and separated an infant from mom yet, now is the time to do that because you need to work with mom. In general, when do we clamp and cut the cord? Well, we clamp and cut the cord when we need to clamp and cut the cord. The baby doesn't need the cord clamped and cut. It's when we need it clamped and cut. So if we're going to have to resuscitate the baby, clamp and cut, separate mom and baby, work the baby. If we're going to need to resuscitate mom, clamp and cut, separate, and start working on mom. Excessive bleeding after the delivery of the placenta is managed with a couple of things. One is if the baby is going to nurse, that would be great. But we can't always count on that. Nursing doesn't happen right away. Latching on is not as easy as it would seem, but it's the stimulation of mom's nipples that causes uterine contraction, which helps us deal with postpartum bleeding. And we need that uterus to contract after the placenta is delivered, and that will be the best way to deal with bleeding. Fundal massage is another way to deal with that. Massage of the uterine fundus, kind of cupped between two hands in a kind of a kneading sort of motion, or your fist grinding on that uterine fundus. It's not fun for you, it's not fun for mom, but this is not a fun case right now. We have excessive bleeding post-delivery and it needs to go away. So nursing and fundal massage together, when those don't cut it for you and you need to add something, keep doing those, and then Pitocin IV or Pitocin drip based on your protocol is the way we go. Usually there's not excessive bleeding. Usually you're down here in the support, reassess sort of mode, and things have progressed pretty straightforward. So we just wanted to go over this flow chart real quick, emphasize the decision point for is birth imminent or not. That's going to involve you taking a look during a contraction, and that needs to happen pretty early on if mom's contractions are less than 5 minutes, and this seems like it's going to happen right now. Get your delivery crew and equipment prepped, and then react based on what you saw when you took a look. Did your inspection reveal a limb or a breech, or a butt presentation, or the cord presenting? If that's the case, all of those are the same. We don't try to do those in the field. We try to avoid that in the field, and positioning is what makes the most sense for us while we rapidly move to the hospital, providing them an early alert. If we're going to have crowning, the head is coming out, then we go ahead and deal with that, get the cord off the neck, suction mouth and nose, get the shoulders out, and then usually it's all about newborn care from there. Mom's usually okay. If not, when that placenta comes out, there's extra bleeding, then we're going to do some fundal massage, see if nursing will work. If not, add some Pitocin to it. And that's pretty much how this goes. It's not really any more complex than that. So now it's time to practice this for sequence.